to the workshop on evolving relationships in place and across provider collaboratives, particularly focusing on mental health, learning disabilities and autism, although I'm pretty sure the conversation that we'll have during the workshop will be relevant to partners across different sectors and providers. So just to introduce myself, I'm not Michelle Moran, I'm a stand-in at short notice. I'm Salma Yasmeen and I'm the Chief Executive of Sheffield Health and Social Care Trust. Delighted to see so many of you at this workshop. We will be having a conversation with three brilliant panel members who I'll introduce quickly, and they'll say a bit more about themselves as they will do an overview of the work that they do in each of their places and in their provider collaboratives. So Jacquie Mowbray-Gould is the Programme Director for Devon Mental Health, Learning Disability and Neurodiversity Provider Collaborative at Devon NHS Partnership Trust. Welcome to Tony Meyer, who's the Provider Collaborative Director at Cheshire and Merseyside Mental Health, Learning Disabilities and Community Services Provider Collaborative. This is long, isn't it?
Yeah.
And welcome to Lynn, I've written it here, Lynn Parkinson, who's the Chief Operating Officer and Deputy Chief Executive at Humber Teaching NHS Foundation Trust. So just before I start, just to say a bit more about me, I'm Salma Yasmeen and I'm currently working at Sheffield Health and Social Care Trust, but I've only been there for 5 months. And as a new Chief Executive into place and into the South Yorkshire system, it's been really interesting to be able to think about actually how do I land into a system where there are already evolving relationships and challenges and potentially opportunities for the Trust with a fresh pair of eyes. And it's felt incredibly important to be able to use some of that to influence perhaps for areas that are challenging for the Trust as well. But prior to that, I was the Director of Strategy and Change and Deputy Chief Executive at South West Yorkshire Partnership NHS Foundation Trust, where we spent 6 years, and probably 5 of those prior to the introduction of the Health and Care Bill, thinking about our role as a trust over a really complex footprint, about the role that we would play in each of our places and across 2 integrated care systems. And I have to say that through that work, we were able to tackle many, many wicked and difficult challenges, including developing a comprehensive provider collaborative in Barnsley with primary care, with the local authority and with the acute hospital, to really think about what would early help look like for people at primary care level, what would a wraparound integrated team look like, and how do we build in anticipatory care, both from a mental health perspective, but also from a local authority and acute hospital perspective. And many of you will know that that system, it faces many of the challenges that you will also face, but is doing really well at the moment. And I truly believe that it was through that place provider collaborative that we were able to address some of those challenges. In Sheffield, one of the things that I really observed when I joined the Trust was that 30% of our inpatient mental health beds had people that were clinically fit to be discharged still in hospital for weeks and for months. That won't be a challenge that's unique to Sheffield Health and Social Care Trust. I'm pretty sure it'll be something that many other trusts also face. And very quickly, through collaboration with the local authority and with our acute trust, we're now looking at ensuring that we've got different pathways, and with the VCS, looking for solutions that we can ensure that we're as ready as we can be, at least for winter. And then we are going to redesign some of the crisis and acute and community pathways. But it's only through collaboration that that's going to be possible. So that's the context within which we'll be having the conversation. But hopefully the panel members will share their insights and reflections from 3 very different places. So starting with you, Jacquie, do you want to introduce yourself and give us an overview?
Yeah, sure. Hello everybody, my name's Jacquie Mowbray-Gould, and as introduced, I'm the Director for delivering the Devon Mental Health, Learning Disability and Neurodiversity Provider Collaborative Arrangements. I think one of the things that you're going to hear today, which is I think it's going to be quite interesting, is that all of the collaborative arrangements that we're going to talk about today, we're all at slightly different points in time in terms of our development. So the Devon Collaborative, which I look after, along with my peer, Dr. Colm Owens, as the medical director, we've been going strong for about 18 months now. And I'd say I'm really chuffed with the sort of work that we've done so far, but we're very much, in my view, at the infancy and still working through very much what the art of the possible is with those collaborative arrangements. So I think that's going to sort of bring a different lens, if you like, today to some of the other participants that we've got on the stage. I think in terms of that sort of ability to come in right at the beginning and come into a system that is in some difficulty, let's say from a financial perspective, you know, there are significant challenges in the Devon system with regards to the urgent and emergency care pathways, etc. Really thinking about what our role and opportunities are that we can play into some of those challenges we've been able to do that from the outset of the collaborative arrangements. And I think equally beginning to think around that place-based discussion. And I thought that was beautifully set up actually by the introduction from Sir Julian this morning, really beginning to think about how can we, what are the opportunities of, whilst we've got some of those major issues that are concerning perhaps the ICS, the ICB, etc., where can the collaboratives get in at that community level and at that place-based level to start pushing the other way? And certainly that population health piece is an area that we've begun to delve into, and if Colin was here today, it's his passion actually is to really drive the health inequalities agenda through the collaborative arrangements. We're probably going to talk a bit more in terms of when we have the questions, but I think the other area that it's allowed us to focus on, and I'll talk about a little bit later, is the opportunities with our voluntary sector organisations. And I know we talk about that quite a lot these days. I would also like to say, because there's some of you in the room that know this, there have been partnerships with the voluntary sector for years in mental health, and it's not new, but it is a real opportunity to really build on those relationships and drive thinking forward. And I think that's one of the areas for myself in Devon to really do some blue sky thinking despite some of those sort of broader health challenges that we know that we're facing, that were so eloquently discussed this morning. So that's sort of where we're at in a nutshell, evolving, taking things forward. I'll probably talk about some of the challenges in a little bit, but what I did want to land on is I also think despite some of the challenges and the strategic sort of issues that we need to think about, collaborative arrangements just offer a really exciting opportunity to do things differently, and this is a real opportunity to open our minds and genuinely start to think differently as systems.
Thank you, Jacquie. And we are going to go to challenges, given you've talked about opportunities.
Yes.
Can you describe perhaps one of the key challenges that your system has faced and how you've engaged with that?
So I think, I mean, the biggest issue at the moment is the sort of focus, I think, particularly on the sort of financial position and the sort of urgent and emergency care. And it can feel quite, I'm going to be honest, it can feel a bit demoralising sometimes to try and get your voice into the room. And I think one of the things in these roles and where you've got those collaborative arrangements is trying to look for the lever, if you like, on how you can both support that wider agenda. So one of the things that we did was we made sure that our urgent and emergency care programme, for example, absolutely aligned with the more strategic ICS issues and challenges, but at the same time really thinking with our VCSE colleagues on what was the art of the opportunity to think about our first response service, as an example. So constantly, I think when you're in these sort of collaborative arrangements, and particularly in leadership roles, trying to, I call it knitting together, but trying to knit the sort of component parts together and sort of deliver a cognizant set of recommendations or help the system think differently about some of the opportunities, and lots of it doesn't cost a lot of money. So it's really, I think that's the biggest challenge, is not allowing yourself to become consumed by the overarching system challenges, but have an eye on it, think about what the opportunities are through the collaborative arrangements to support that, but I think equally at the same time continuing to have the narrative to make sure that you've got that community focus still built in there, and I think that that's the role that I play at a system level.
Brilliant. So really convening partners to come together right across the system and sector. And has that work included mental health?
Yeah, it's all, yes, right, absolutely. So I mean, I did forget to say, and it is, I mean, I think keeping mental health on the agenda in these times is really tricky. I think, and this is a very personal view, I think there is some unhelpful narrative about mental health at the moment, which stigmatises and silos mental health ever more than it ever has been. And I think there's a requirement on us in the mental health collaborative space in particular to not let that win the day, and to keep proactively and positively moving the mental health agenda forward, but in a system partnership focused approach. So I think there is I think it's really important that those of us in the mental health space, and my job is purely mental health and learning disability, and by talking about mental health I do include learning disability and neurodiversity. There is a genuine opportunity for us when we're in leadership roles to make sure that we don't become consumed by perhaps a more negative narrative. It allows us that opportunity to, push the agenda forward in a more positive way.
Thank you, Jacquie. So parity of esteem is absolutely key. And then moving on to you, Tony, just to give us a brief overview.
Thank you, and hi to everyone. So I am the director here in Cheshire and Merseyside of the Mental Health, LD and Community Service Provider Collaborative. And I think the difference that I'm hoping to offer up compared to Jacquie is that bit on the end, the community services aspect of it. We've had a similar story as Jacquie's just told with the mental health. However, I think it is subtly but importantly different when it comes to community services. Within Cheshire and Merseyside, we are a big ICB. We've got 9 places, we've got 9 local authorities, we've got 9 providers of community and or mental health services. And that would be complicated enough if each of those 9 places, 9 providers and 9 local authorities were all coterminous. They're not. We've got places that have more than 1 provider, and we've got providers that cover more than 1 place. So it is a complex arena of organisations and of relationships. Each of our community and mental health providers are set up differently as well. So we've got organisations who are purely delivering NHS community services. We've got organisations that are delivering community services and secondary care services, and we've got others that are mental health and community providers. So again, they all come from a slightly different angle. They have slightly different priorities and a slightly different view of the world. I feel like I've been having this conversation around evolving relationship between provider collaboratives and place for the last couple of years now. We did a lot of engagement right back at the start around, okay, what are we here to do? We've got a provider collaborative. We needed to answer the so what question, which we got from a lot of areas. We got it from the ICB, we got it from local authority, we got it from secondary care. What are we actually doing that is different to what other people are doing. I think the concerns we found at the start from the place teams was around duplication. They felt that what they were doing was operating in that community space, and all of a sudden we've got a community provider collaborative that are operating in that space. So is there a risk of duplication? Are we all doing the same thing in opposition to each other? I think when it came to local authority, there was a particular concern around the community services aspect of our provider collaborative, because local authority, as a sweeping generalisation, you'll have to forgive me for this, felt that there was a challenge there in terms of limiting their ability to test the market, to tender for services and get a number of responses back. What they felt they needed was an environment where there was competition, so that would deliver the best value for money for the services they were commissioning. Their concern about 9 providers all coming together with a view that we will collaborate, not compete against each other, was that we would essentially create a cartel of sorts. And that was a real concern that we had to get over. I think the concerns that we had from secondary care colleagues were, what were our priorities going to be? Were they going to align with the very well publicised and well recognised priorities that secondary care are facing? Are we going to go off and do our own thing in the mental health and community services world, or are we there to help with the elective recovery and the urgent care agenda? So there was a lot of people right at the start with different views around what we needed to do, and we needed to somehow come up with something that would allow us to create a list of, or a programme of activity that was going to prove our worth. We needed to build trust in the provider collaborative as an entity. I think when I look back, we started out with an agenda that was way too ambitious. There were discussions right back at the start of, okay, we've got this amazing opportunity of, for the first time in the history of the NHS, we've got a mandate for providers to work together. And therefore, if we work together, we can do something absolutely transformational in the space of community and mental health services. I think what we very quickly realised was that transforming the world over the next 6 months wasn't going to be accepted by our partners. We needed to prove our worth. We needed to build trust. We needed to build those relationships with the place teams and with all those different partners with a different view. And effectively what we needed to do was find some common ground. We've ended up having to, water down is probably the wrong phrase, but we've had to dilute the ambition of the collaborative for now in order to build that trust. We've had to work in the space of what is absolutely a no-brainer, something that exists in the opportunity should be done at scale and should be done in collaboration. And there are a number of examples of that around community waiting times, around intermediate care. There's a whole host of those that really it'd be very hard for anyone to object to. The risk is we stop there, that we do some of that easy, and it's not easy, but easier transformational work across Cheshire and Merseyside, and that's the entirety of our ambition. I don't want it to stop there. I think it's a starting point as the system matures and as those relationships evolve, and then the bigger opportunities come later on the back of that. So we've done a lot of work to get where we are. I think we're in a very, very different place to where we were 12 months ago in terms of those relationships. I think our partners get us. They might not necessarily believe that provider collaboratives are the answer, but I think they understand that we are here to try and help, and have bought into that.
Thank you, Tony. And I was going to ask you about opportunities and benefits, but I think we've covered some of that already. So I'll just go straight to Lynn.
Yes, thank you. So I'm Lynn Parkinson, and I'm the Deputy Chief Executive and Chief Operating Officer in Humber. So here today just to talk a little bit about the Mental Health, Learning Disability and Autism Collaborative in the Humber and North Yorkshire ICS. Similar to other colleagues, the Mental Health LD and Autism Collaborative began as a partnership around sort of 4 or 5 years ago now, and obviously has been through that maturing, developing process that colleagues have talked about already today. A little bit about Humber and North Yorkshire. So there are 6 places in Humber and North Yorkshire, and in terms of collaboratives, obviously the ICB has worked to think very clearly about the architecture of the collaboratives and the relationship with place. So there are 5 collaboratives now. So we do have a separate community collaborative. Perhaps that might be an area, as you've already touched on, perhaps to come back to how the collaboratives relate to each other as well. So in thinking about specifically the relationship between the Mental Health, Learning Disability and Autism Collaborative and Place, that really has been at the heart of, as we've already talked about, a lot of conversations about how that relationship, how that partnership works, how it serves the populations in the right way. So I guess we've got to a point where we absolutely recognise that, you know, individual providers obviously are both a part of place and a part of sector collaboratives. That when they are in place, perhaps they are representing their sector, and when they're in the sector collaboratives, they're representing their places and really getting that sort of conversation and understanding right across those areas. Again, in the RCB, we've really thought about the architecture. So our collaboratives are supported with governance arrangements. They do differ across the sort of 5 collaboratives. The Mental Health, LD and Autism Collaborative is supported by an MOU. There are partnership agreements in place across the others as well. And it's been really important, as I've talked about, to really get that engagement around developing that architecture and what feels right to represent our populations well. So I guess, as others have talked about as well, we really do think that the collaborative and the conversations we have with place are really about sharing, learning, partnerships, collaborating, and it has taken time, there's no doubt about it, to get to that sort of level of maturity. The importance of local authority colleagues, wider communities, VCSE, stakeholder and clinician engagement has been really key as well. So our Mental Health LD Collaborative has a very engaged clinical assembly, now practice assembly, with wide engagement as well. Our Mental Health and Autism Collaborative, I think that question around sort of what the focus is, what the priorities are, as others have said, is really important, and that, you know, has taken leadership and work to get to that point around sort of what we understand that to be. Ours is supported by a strategy now that underpins the collaborative. I think coalescing around sort of what we've understood are the key priorities for our collaborative has been important. Obviously that's subject to revision undoubtedly, and you know, wider engagement with the communities. I think we've worked really hard to get the community engagement right. I think it's still an ongoing challenge around that, and we need to continue to think about how we're doing that effectively. We talk about co-production in our collaborative a lot. We've got examples where we can certainly demonstrate a lot of our priorities have been developed through that co-production collaborative approach, but I think again we've got more work to do specifically around that development. So I think we've built on success as well. So we've had good examples of where we've, you know, really looked across the providers, the other participants, partners in our collaborative, and understood where the sort of expertise lies. You know, that's been really, you know, really positive in terms of understanding the added benefits that the collaborative has brought. So we have got examples where we've had a particular focus. For us right now, we're very focused on community, as others have talked about, that community mental health initiatives around integration with primary care. And again, we can now sort of cite some really positive examples of improvements taking place as a consequence of that collaborative working. A good example for us would be an increase in the percentage of the population that are and have undertaken health checks for seriously mentally ill. We were struggling with that across our places, and we can now demonstrate some continuous improvements around that. But I think just going back to, you know, the partnership is key, and keeping on focus on that, and that actually that partnership working collaboration, you know, really does need to be supported. So our collaborative as well, we've undertaken some leadership development programs to support that maturing of the collaborative approach.
Brilliant, thank you, Lynn. So while I ask these guys for one more question with a succinct response, I'd just invite you to think about some questions yourselves. And there is a roving mic somewhere, brilliant, there it is at the front, that'll come round hopefully if you stick your hands up. But just really succinctly, just invite each of you just to offer, I guess, what key message would you want to share with the audience about what they should be thinking about in terms of provider collaborative?
So succinct. I'm not known for being succinct, so I'll give it a bit of a go. And this is, again, a personal view from what I would describe as an emerging collaborative arrangement. So I think trust, engagement, two things actually that are really making a difference, which is wider clinical engagement. And by that I mean really getting clinical leaders in your system to take forward pieces of work. So the piece for me around bringing the GPs in with who might have a particular interest, say in physical health checks, that is an absolute game changer. So really sort of thinking about who those community game changers are, and they're often your GPs and others, and bringing those in. And then I'd say the co-production piece, so genuine co-production, really listening, not just to our communities and population, but the people who use our services, and making sure they're absolutely in the middle of the decision making and the thinking.
Brilliant, thank you. Johnny?
I think for me the main thing that we didn't really start moving forward at great pace until we'd sorted out was the communication. So letting partners know what it is that we're doing, because there was an awful lot of people, in the absence of information, were making their own minds up about what it was they thought we were about. So being really, really clear and providing that communication on a regular basis as to what we're doing, but then also the communication on what we've achieved, so those success stories. Because as Jackie's just said, and we've heard from a few of us, it's building that trust. Provider collaboratives are new. People mistrust something that is new, therefore we need to give the evidence so that we can build that trust and then move forward. So communication.
Brilliant, thank you.
And for me, I think it would be very similar. I think that trust, building the relationships, building the partnerships, keeping the partners engaged, and then obviously developing what we think are the collective priorities together with that co-production, community engagements, which, you know, keeping that at the heart and essence of the work of the collaborative. It requires a lot of effort and attention. Yes. So I think it's just keeping that in mind. And as you say, it was building on success, and actually, you know, really building on that, you know, actually we can demonstrate that actually by doing this, we actually are improving the services and the experience of our service users.
Yeah. And yourself.
And I guess I would say evolutionary rather than revolutionary. Yeah. And clearly it's really, really hard work, collaboration. Yeah. But I think what we've heard is continue to build on what's already there and what matters to all of you, and really try and create the alignment. That feels really important. I think that we've heard that through all three of the different stories. So just opening it up for questions. Has anybody got a burning question? There's one there.
Thanks very much. So in terms of engaging the third sector...
Do you want to say who you are?
Oh, sorry, Graham Russell from Gloucestershire Health and Care, non-exec. So in terms of engaging with the third sector on mental health collaboratives, could you say a little bit more about what collaborative commissioning looks like and also what collaborative cash looks like? Thank you.
Oh, gosh, great question. Yeah. Who wants to take that first? You want to...
Yes, thank you. Thanks for that. So, collaborative commissioning is a really difficult one, but a very topical issue at the moment. We've not moved into that space yet. We've talked about it an awful lot, and I think where we've struggled is because of the governance arrangement. So our collaborative, we're not a joint committee, we're not even a committee in common, we are an arrangement underpinned by a memorandum of understanding that where it suits us to collaborate, we will. There's no obligation for us to agree with each other, and there's no formal process in place whereby if 5 of the 9 providers all want to do something, the other 4 have to. So if you transpose that into a commissioning space, it's unachievable until you've got that governance structure in place. So we've steered away from it for now, although I think if we're going to realise the scale of the opportunities in the future, we need to grasp that. The only exceptions have been the areas where we've had the lead provider collaboratives for specific services. So for eating disorders, for the mental health secure services. And that's worked well, but it's been very labour intensive for a relatively small service. If you transpose that over the entirety of mental health or mental health and community, you'd have an awful lot of lead provider collaboratives being established, and I don't think that would be the best model. So I think it's tied into the governance question that we've yet to answer.
Thank you, Jackie.
Thank you. So I completely agree, but I do think that there were some opportunities through the Community Mental Health Framework as an example. And I know that some parts of the country really did focus in on that opportunity to commission differently with their local VCSEs. It's just one example. It's still, and it's really interesting actually, a few years ago, or 10 years ago, we went in a different organisation to work with a VCSE organisation in a joint venture. So this is, again, not new stuff, so it has happened previously. But at that time, it was very much mirror contracting. And I think there's still a little bit in the realms of mirror contracting or subcontracting. What the conversation we're beginning to have in the Devon system, despite the collaborative sort of infancy, if you like, is we are beginning to think about our VCSE alliance, as we call it, as a key strategic commissioning partner. So I think building on some of those opportunities, that historical opportunities where we've always worked with the VCSE, working, I think, through sort of opportunities such as Community Mental Health Framework, think what we've whetted the appetite of our VCSE colleagues to think, hang on a minute, we can offer you so much more in this space. And in my system, in Devon, I think that is leading to some really interesting conversations. We've got a Blue Sky Thinking event in December, and it's very much on what more could we do if we chucked the rule book out a little bit in this space. So I think it's a great question. Again, early days, but one that for me in the collaborative space, really excited about.
And perhaps I'll just add to that in my previous role, we had, certainly in the place provider collaboratives, VCS partners being part of that and at the table, particularly when deciding what the priorities were and how we might spend the mental health investment standards differently. And that's been really positive, because what we have seen is things like crisis cafes being developed, which are an integral part of that acute and community and crisis pathway, rather than just being seen as a bolt-on. And there's probably potential to do more of that, I think, as we deepen collaboration in each of our places. Thank you for that question. Anybody else? Oh,
Hi, it's Ellie Orton from NHS Charities Together. And just going on from that, what are the barriers for greater collaboration and collaboratives with the voluntary sector?
Great question.
Oh.
Capacity.
So capacity to a degree, I think current procurement and commissioning legislation, etc., but that's changing, as we all know. So I think there's some new opportunities on the horizon for thinking a bit more flexibly and a bit differently. I think as well, I'm going to go back to trust, and I think that's both ways. I don't know if there's any VCSE colleagues in the room, but you know, I think when, you know, we started talking about the big conversation, etc., all those years ago, you know, political piece, there was perhaps a view that the charitable section, the VCSE section, would come along and do things more cheaply. I'm just speaking honestly here, and I do think that was a little bit of the discussion, the national discussion. I think that's not we're moving away from that, and this is about true partnership. But I do think some of the sort of rules and the sort of procurement and commissioning landscape that we currently sit in doesn't support you know, where we would like to get to in true collaboration, true joint commissioning, strategic commissioning with our VCSE colleagues. But I do see some light on the horizon for that, and I do think that narrative about this being, you know, this group being able to sort of get us out of a difficult situation, I think that has dissipated over time, and there's a lot more respect for each other, but we need to continue to build on that.
Thank you. And Lynn?
Yeah, and in terms of what's happening in Humber and North Yorkshire and the Mental Health and LD Collaborative there, this is the conversation that's very live for us right now. So we're really absolutely considering those operating models going forward, given where our collaborative has got to. VCSE partners are very vocal, unsurprisingly, in that conversation about where they feel that they would like to sit within that arrangement going forward. So I think for us, very similarly, you know, it's the next step in terms of, you know, maturity. There are challenges, undoubtedly. For us, capacity is a real challenge. We've got some great examples, but they're usually sort of subcontracted type examples, you know, where that level of knowledge and expertise actually sits better in the VCSE than it does with statutory providers. I think that's really well understood. And that difference of culture and approach as well, and the value that brings to services as well. So that really is, you know, where we are really considering next steps for us right now.
Yeah, brilliant. And
sorry, there is a conversation though that is growing, and I think that, again, this is really important if we're going to work collegiately and in partnership with the VCSE in a really meaningful way. You know, there was an interesting discussion recently at a national call I was on with regards to evidencing delivery through our VCSE colleagues. And I do think that, you know, the governance arrangements that we've touched on as well today through those collaborative arrangements are absolutely imperative. If you know, we're spending public funds, we need to know how we're spending those funds. And I think that's a bit of a live conversation at the moment, particularly when you could have any number of VCSE organisations delivering along those pathways. So that governance arrangement that we touched on earlier is really important in that space.
And the only thing I would add is that it's really important to invest in the voluntary and community sector's capacity to be able to engage in the numerous ways in which we try and engage people through that collaboration process, because that isn't necessarily always built in. They don't have the level of scale that I guess we have in the NHS organisations.
I think that should be on the risk register of every ICB.
Yeah.
Capacity of the voluntary sector.
Absolutely.
You know, Sam Allen's there talking about partnership with the voluntary sector. You're talking about the voluntary sector.
There's nobody on the panel from the voluntary sector.
Really good
There's
point.
not many people in the room, probably apart from me. And I wear two hats of NHS charities, so 100% voluntary sector, but based within the NHS culture, if you like. And the capacity of the voluntary sector, I do think needs to be on the risk register of every ICB.
Yeah, great comment. And
Really
I think fair challenge. I think you're absolutely right. There's nobody on the in this conversation, at least here. But certainly something I think, you know, everybody recognises that, but I think that point about investment is something we'll have to keep coming back to. But great suggestion about adding it to the risk register. Yeah, thank you. Any other questions? One there and then one here.
The one
Yeah.
this way, yeah.
Thanks very much. It's been really interesting. It's Zoe Billingham. I'm chair of a mental health trust, Norfolk and Suffolk. We're a challenged trust, and I need your help. I've sat listening to the great gains you've made through your collaboratives, and I congratulate you. And I wonder if there's more that we can do as chairs of provider organisations. We have a unique position, don't we? We can say things and all they can do is sack us and who cares? But seriously, the issue for me is, and this is not to take issue because I agree with you, evolution, not revolution, but is that ever really going to get us to where we need to get to in mental health? When we talk in tables around our ICBs, it's still completely focused on ambulances and elective surgery and winter pressures in the context of physical health. It is accepting that evolution, not revolution, is the way forward okay, or should we be agitating for a little bit more revolution? And if so, what do I need to do as chair to help that?
Gosh, that's a brilliant question. Yeah. Brilliant challenge. So, does it? Because I've got some comments, but go on.
Thank you. Yeah, and it's really, really good point. And if I look back at the journey that we've had as a provider collaborative, there was a very definitive point where I hosted a workshop with the chairs and NEDs of the 9 organisations. They were all invited, and by and large they came into the room, and a lot of them had very grumpy faces on them. And that was because the provider collaborative had been in existence for 6 months, and it's the first time that we'd invited them in. Now, the positive side of me took that grumpiness as enthusiasm for wanting to get involved. And actually what transpired was that they have become very active within the provider collaborative space, and it's been incredibly beneficial to use the chairs and NEDs, not just because of their roles of chairs and NEDs of the organisations, but their links into so many other sectors. By and large, you tend to have other roles or numerous roles in different areas, and I think that has really, really helped us to push the agenda of the provider collaborative and the idea of the provider collaborative. In terms of your evolution or revolution, you know, I'd stand up right now and shout out for revolution. I've tried it. We haven't achieved it. I've had to, you know, calm myself down a little bit with how fast we can go. If we can build that momentum, though, yeah, evolution's going to take a long, long time, and I think we all agree we haven't got a long time, have we, to make significant changes. So, yeah, vive la revolution.
So I suppose, I mean, I've got my chair here in this room, and she chairs the provider collaborative for mental health, learning disabilities and autism across our system, which is really positive because I think, you know, that enables us as a trust. And we have been challenged. I've joined a trust that's fragilely out of RI, has got a huge number of challenges that we need to focus on. But I think really investing in and carefully thinking about that distributed leadership is going to be absolutely key, because it shouldn't just be the chair and chief exec. But I think the chair playing into that space really helps us. I think the second thing I would say is that, you know, change happens at the pace of trust. We know that. And actually it's really worth investing in building trust and trusting relationships. And that doesn't mean just holding hands and, you know, playing nicely. It means having really uncomfortable and challenging conversations. And I think that's the revolution. But actually you have to do it in an evolutionary way, because if you don't take people with you, people don't turn up at meetings, you have circular conversations. It's all the frustration of collaboration. So I would still stick to saying it is evolutionary, but I think within that it's about having honest, open, challenging conversations about what the wicked issues are, and continuing to have those. And I think it's through that you'll find collective solutions, I think. And I think that's the experience that we gained, certainly when I was at South West Yorkshire Partnership NHS Trust, where there were really entrenched, difficult relationships in one of our places. and some really wicked performance issues right across the system. It took us about 5 years, but the outcomes have been absolutely worthwhile, I think. Thank you. Have we got time for one more question? Yeah. Sorry, Kath there, because she had a hand up, and then that gentleman, quickly. We'll try and be succinct.
Thank you. I'm Kath Lavery. I chair Rotherham, Doncaster and South Humber FT. But I'm going back to the VCSE stuff, Salma, with apologies, because I've been the chair of several charities. And some of those have delivered NHS contracts.
Yeah.
Particularly in sport. Just a small shout out for Rugby League, but, you know, I chaired the Hull Kingston Rovers Foundation for about 10 years. Any chance to say up the Robins, yeah. But that issue of investment in the third sector is crucial.
Yeah.
You know, you cannot get the money to cover your overheads. So everybody's willing to pay you to do X, but they want every penny of that to come back in a governance way, what you were talking about in outcomes for community. And you can get into those communities, those poor communities in areas like East Hull, where I was working, in a very different way to mainstream services. It is very, very different relationship. But if nobody's going to pay you for your director or your accommodation or your telephones, you can't exist.
Yeah.
And if you say, well, I need 10% on top for management overheads, to go, no, absolutely not. You know, now a problem. Well, then you simply go under. And, you know, I've been so close with several charities that you're just scraping by day to day. And on a couple of occasions, not being able to pay wages on a Friday because you just didn't have the money in the bank. You've not got those big balances in the bank. So if you want them to get involved, if you want them to be part of it, you've got to invest in their existence and start paying for services that are going to exist over, say, 3 years, not 6 months.
Yeah.
They just cannot do it. And yet everybody sort of goes, yeah, we want you at the table, but we're not prepared to ensure that you exist. It don't work. I'll shut up.
I that's maybe the revolution, not the evolution piece for me. I couldn't agree with you more. And I'm not third sector, but it's an area in my whole career, 34 years in the NHS, I've always had it's not even, it's just a natural connection that for me has always been present in the work that I've done. And I absolutely agree with you. And those are the conversations we are absolutely having in our system. And it's quite interesting because I now have a number of those contracts. And I'm going to be totally honest, at the moment, I would say that they're sticking plaster contracts because they're contracts that have come in over the years to, perhaps help us get over the line with a particular area where we haven't been able to move at the pace in the NHS. But the conversations we're having with those organisations is exactly that one. How do we put you on a sustainable footing? There's a real ambition in our collaborative to think about 3 and 5 year contracting through sort of alliance contracts and what have you. And that point you're making about overheads, we absolutely have to address it. It's just not fair.
Lynn, did you want to come in?
Yeah, I'd just like to endorse that, really. I think that partnership with the VCSE is actually a necessity in terms of tackling, some of our key challenges around demand and complexity and workforce for the future as well. We absolutely need to address those issues, Kath, that you have just raised there. I'd like to think we've got some really good examples in Humber and North Yorkshire where we have respectfully engaged with and contracted with the VCSE in the way in which you're describing, but it's not across the board all of the time. But I think that absolutely is. Those partnerships are absolutely key and absolutely where that focus needs to be for the reasons that colleagues have said.
And it does, though, go back, I think, to the very first question around commissioning and the infrastructure that we're working within. And I do think, whilst there's some positives coming down the line in January around that side of things, I think we're still going to need more from a national perspective to really get this right going forward.
And just to add to that, I know that in West Yorkshire several years ago, and I don't know if there's any West Yorkshire ICB colleagues here, but I know the ICB, led by the voluntary sector, did a State of the Nation kind of review and report about capacity and what was needed for the voluntary and community sector to actually play a stronger role in delivery of care. And part of that absolutely raised the issues about ensuring that capacity was there to engage, and secondly, that actually we were considering overheads and commissioning properly sustainable involvement or delivery of care. So I think there are some good examples around that we could probably learn from the systems. But thanks for that question, Kath. There was one more question there, and we'll probably have to bring it to a close.
Yes, thank you very much. My name is David Tito, Associate Director of Corporate Governance at Birmingham Solihull Mental Health Foundation Trust. My question, Tony talked at length about the meeting you had with NETs and chairs of boards. I'm just wondering, in those conversations, how do you take the Council of Governors, or have you had experience of taking the Council of Governors along that journey, and how have you got them involved in that space? And the second question is around accountability, vis-a-vis or against the principle of collaborative working. How do we hold partners accountable, or do we sacrifice governance, good governance, on the principle of collaboration? Thank you.
Great question. Do you want to?
Thank you. So in terms of the Council of Governors, we've not got into that space yet. I think one of the difficulties for provider collaboratives is we're nationally mandated, aren't we? It's very clear that organisations, particularly mental health and acute, have got a duty to collaborate. When I go to some of the ICB exec meetings in Cheshire and Merseyside, some of the discussion there is we either all succeed or we all fail. There is no single organisation succeeding at the expense of everyone else, which is all well and good. But when you take that into the trust board situation with the Council of Governors, with the non-execs, the role of the trust board is to ensure that that organisation succeeds. It doesn't currently have any responsibility for ensuring that the system succeeds. So we've got a real disparity there between what we're saying we want as a system, but then as soon as you go back into your own organisations, it's, okay, how do we make sure that we're safe? And those two things quite often collide. And I think that is one of the difficulties of the provider collaboratives at the moment.
Lynn, did you want to say from Foundation Trust perspective?
Yeah, I think that's a really good question, the role of the Council of Governors particularly. I think it's fair to say that we absolutely engage our Council of Governors in this conversation. Their feedback actually has been integral as well, undoubtedly. But I think, again, given the conversation I discussed earlier, really thinking about the maturing of the collaboratives in our area, actually, I think, that's a further conversation that we're having as well. What is that sort of role there, and what should and could that be going forward? I think that question of accountability is really key as well in terms of how colleagues have already discussed it. But I think, again, for me, it's just really important that we're having those conversations. We really are engaging and really trying to, really understand what's at the root of that. So I think we're well on the way with that, but undoubtedly, as others have said, I think that's certainly work in progress still.
Yeah, and I might just build on that, sharing my experiences from my previous role, where we were doing really, I suppose, high-risk arrangements in partnerships where it might have involved giving up something or giving up some of our services, or taking on a new arrangement that was perhaps, the board felt that it was high risk. It was absolutely key to keep the governors on that journey and on board with it. So regularly having conversations with them is absolutely key. And certainly now we're in a similar position in the new trust that I'm in. And I think governor involvement and linking it to your annual priorities and making sure that that's visible is absolutely key. Brilliant. Any final questions before I summarise? No, you're all ready for lunch, aren't you? Okay, so thank you to our brilliant panel. I'm sure you'll join me in just saying thank you to them.
Well done to you.
But just to summarise then, I guess whether it's evolutionary or revolutionary, that will remain a debate, an ongoing one, no doubt, and one that will remain political, I'm sure, as well. But I think some of the consistent themes that we've heard is collaboration is not easy, but absolutely necessary if we're going to address some of the key challenges that all of us face, irrespective of the sector that we're in. And at the heart of that has to be relationships and an investment in building trust. Being clear about priorities and building momentum is certainly what we've heard. Also, parity of esteem, really paying attention to partners that are present right from the outset, including the voluntary and community sector, local authorities and beyond the NHS is key if we're going to really realise the potential opportunities and benefits of collaboration. Communication and really keeping people engaged and involved, and that distributed leadership is key. And then finally, accountability is really important as we work through new ways of working and the different types of governance that will keep us safe and enable us to collaborate moving forward. Thank you all. Thank you again to the panel.